Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast Studio in Fall River, Massachusetts. Today we'll be discussing fatty liver disease with Dr. Tamer Yacoub. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. In Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centreville. For more information, visit their website, duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and 5-star reviews are always greatly appreciated. So, Dr. Yacoub, tell us first, because I'm sure we know you very well, but tell the audience a little bit about yourself before we get going so they can understand where you're coming from.
Sure. Well, first of all, thank you very much for inviting me. I think this is my third time at your podcast, and it has been such a pleasure being here. So I am board certified in endocrinology. I've been practicing in Fall River since 1996. So that's 28 years and counting. And 8 years ago, I became board certified in obesity. You probably know that Fall River leads the state of Massachusetts in obesity and diabetes.
Yes.
And one of the complications of obesity and diabetes is fatty liver disease, which is the topic of our conversation today. And it is becoming a major health problem. Just to give you an idea, we have 35 million people with diabetes in the United States. We have between 80 to 90 million people with fatty liver disease. A small portion of them are going to progress and will require liver transplant at some point in their life. Mm-hmm. And that's why there is a huge campaign from all of the medical society to raise awareness about fatty liver disease, who are patients at risk, who to screen. And for the first time in history, we actually have a medicine that is FDA-approved for treatment of fatty liver disease, which we will be talking about during the podcast today.
Do you think patients understand that it's a serious condition? Because I think a lot of patients don't understand that. They don't realize that it can progress to advanced liver disease and even, as you mentioned, transplantation, cirrhosis.
That's very true. Actually, both patients and a lot of physicians do not take it seriously, because the vast majority of the patients do not end up in trouble. But a small portion of those patients who end up having progression of the disease, those are the ones who end up having some serious consequences down the road.
So I have a couple of questions already. I didn't know that Fall River was leading Massachusetts. I knew we were not great health in this immediate area, but why Fall River? Like, out of all the other cities in Massachusetts?
I think part of it is genetic. So I did some research, and it turned out that 70% of the population of Fall River are of Portuguese descendants. Mm-hmm. Portugal is leading Europe in diabetes in Western Europe.
Okay.
So the highest incidence of diabetes is in Western Europe. So clearly the Portuguese gene has something to do with it. You move from Portugal to the United States, where you have less physical activity than back home and plenty of food. So you tend to overexpress some of the genes, which are the genes for obesity and diabetes. And as you know, as you have higher and higher prevalence of obesity, you will have higher and higher prevalence of diabetes and cardiovascular disease. But those two, they tend to go hand in hand, obesity and diabetes. They actually call it diabesity now.
Oh, I didn't know that. That makes sense, though, right? Huh. So, with the fatty liver, and when I hear medical people talk about it, sometimes you're absolutely correct. I don't hear the gravitas that it should be spoken about then, because they're like, I'll hear like a patient go, oh yeah, I have fatty liver, but there's no like follow up to that. It's just like they got that result and it was just like, oh, by the way, you have a fatty liver,
Correct. Well, I mean, that has been the case up until 5-6 years ago. And now there is like a major campaign to educate both physician and patient about the disease. We never had any effective therapy, but now we do have one. And now we have a better understanding of how the disease progresses. And now there are a lot of preventive measures that he can do to slow down the progression of the disease. And if you catch it early enough, you can actually reverse it.
So how does the liver become fatty? Like what? Because I think a lot of people just think of like liver disease maybe associated with alcoholism and maybe starting with the obesity and stuff. But when you say fatty liver, like what actually happens to the liver and what's making it that way?
Okay, well, that's actually the root of the problem. So as we are eating more food, so the body has to deal with the extra fat. So you have one of two ways to store the fat. One is the fat cells that store the fat. It's called adipocytes. They multiply in size so they can accommodate the extra fat while maintaining their normal function. The other dysfunctional way is each fat cell will accumulate more extra fat than its capacity. Okay. And when you do that, you reach the level that you can no longer store the fat and the fat will leak. So the function of the fat cell is to store fat when we are eating and release the fat when we are not eating. And this way we can provide the body with whatever calories, because the main function of fat is to burn and get calories. So when the fat cells are oversaturated with fat, you have constant release of that fat. We call it ectopic fat deposition, meaning fat end up being stored where it doesn't belong. If it is stored in the liver, this is fatty liver disease. If it is stored in the pancreas, this is insulin resistance and eventually can cause diabetes. If it is stored in the blood vessel, that means increased risk for heart disease, peripheral vascular disease, stroke. If it is stored in the internal organs, that means inflammation and procoagulation. So fat where it doesn't belong always causes a lot of problem. And that's why you never see fatty liver disease by itself. You usually see it associated with other problem related to fat storage like diabetes, high blood pressure, high cholesterol, obesity, and so forth.
So can skinny people have fatty liver?
I was just going to comment on that because you do see that.
Yes. So there is a genetic disorder where people are lean, not overweight, and they can carry extra fat and have the same problem with fatty liver disease. But that is the very, very rare exception to the rule. But it can happen.
Okay.
So the treatment has always been, weight loss, exercise, limiting alcohol intake, but people have so much difficulty with that. Obviously, especially the weight loss part. What's been your experience with that? Do you think this medication that's available, which we'll speak about, is going to be a game changer for the condition?
I think it's a combination of all of the above. As you said correctly, it is easier said than done. Right. You need to exercise, cut back on your calories, and you'll be fine. I mean, if this is the case, everybody will respond, and we will not have any major problem. So when we started our weight loss clinic here at Primacare back in 2017, I expected that the vast majority of the patients who will come and see us will have diabetes. But the most common denominator in our patient was fatty liver disease, which usually start many, many years before diabetes. So we invested in a machine called FibroScan, which is a very nice way that you can actually scan and screen patients for fatty liver disease, and you can actually follow them and see if they are progressing or not. And to my surprise, we actually did a decent job. So our average patient in our weight loss clinic, they lose anywhere between 12 to 15%. Younger people tend to lose more. Older people tend to lose less. Mm-hmm. Those patients, when we repeat their FibroScan, we found that within 6 months to a year, they have complete clearance of what's called steatosis, which is the fat in their liver, and decrease of the fibrosis score. Fibrosis is the scar tissue that develops in the liver after you have fatty liver disease for a long time. And it goes in stages. F0 means there is no fibrosis. F4 means cirrhosis or end-stage liver disease. And F1, 2, and 3 is mild, moderate, and severe. And we found in our patients who lose the weight, their fibrosis score dropped by 1 point. So they go from F3 to F2 or from F2 to F1. And studies showed that patients who have worsening of fibrosis score, they tend to have more complications of liver failure and needing for dialysis. And patients who have improvement of their fibrosis score, they tend to have less liver disease. Okay. They also found that fibrosis score correlates with some other non-liver complication, which usually goes hand in hand with fatty liver disease, like heart disease and diabetes, high blood pressure, and high cholesterol. So fibrosis score is actually, it's a very good surrogate that you can follow if it is progressing or if it is regressing. However, 12 to 15% weight loss is not really an easy thing for patients to do on their own. Most of the patients who do a self-directed program, they are successful to lose 5 to 6% of their weight. But unfortunately, it is not sustainable, and within 6 months to a year, they gain the weight back.
Oh.
So going back to answer your question, it's all of the above. So for a successful weight loss, you need to lose at least 7% of your weight to clear the fat in your liver, and need to lose at least 10% of your weight to improve your fibrosis score by 1 point. After that, you need to work as hard to maintain the weight so you do not gain the weight back. And that boils down to the 4 basic things, which is good nutrition, regular physical activity, medication, if they are candidate for, and what's called cognitive behavior therapy, which is basically you need to change your mindset about your lifestyle, the way you eat, the way you exercise, the way you sleep, and how do you manage with the stress management.
Mm-hmm.
Dr. Yacoub, what about, I have 2 questions. So if you're at the cirrhosis level, and that was F5?
F4.
F4, can you regress from there? Or once you hit cirrhosis, can you see, like, can you move back down? Or is that kind of like, the point of no return?
So there is compensated and decompensated. Compensated, that means that they really have significant fibrosis on their liver biopsy or on their imaging, or the biochemical markers that we will discuss in a few minutes. Compensated, that they already have started to have the complications of end-stage liver disease, which is the esophageal varices that can cause bleeding, and some other complications as far as coagulopathy and bleeding. So once you advance to that level, unfortunately, it is the point of no return unless you get a liver transplant.
Mm-hmm.
Okay.
But even in those patients who are compensated, there is some data to show that you might be able to make some improvement. But again, the further you are in the fibrosis stage, the less likely that you're going to reverse the disease, which brings us to this podcast, which is raise awareness of the disease so you can identify it early, deal with it before you have any serious complications.
So let me ask this question. I mean, I know the way I work this up, but I'm curious, what your standard is. So if someone comes to you and has abnormal liver function studies, how do you approach that?
Okay. So there are multiple risk factors for fatty liver disease. One of them is abnormal liver enzymes, as you mentioned.
Mm-hmm.
People who are obese, patients who are diabetic.
Okay.
So there's something called the metabolic syndrome, which is increase of the waist circumference more than 40 inches in men, 35 inches in women.
Okay.
Patients with high blood pressure, patients with abnormal cholesterol, which is triglyceride above 150, or HDL, which is the good cholesterol, under 50 in women, under 40 in men, and diabetes and prediabetes. So if your patients have 1 or 2 components of the metabolic syndrome, that's a red flag. Liver enzymes elevation is usually common, and it's one of the early ways of screening. So there are 2 enzymes called ALT and AST, and usually if the ratio of the ALT to AST is more than 1.5 times, that's usually a red flag. So the liver enzymes does not have to be abnormally high, but if the ratio is more than 1.5, that's usually a red flag. So there are what's called NIT, non-invasive testing. So back in the days, the golden standard was to do a liver biopsy, which is too invasive and very difficult, requires a lot of skill, and it's very cumbersome to the physician and to the patient.
Mm-hmm.
So now we have those NIT, which is non-invasive testing, which is 2 portions. One portion is blood test, and the other portion is imaging. The blood test, there is multiple things. One of them is called FIB4. FIB4 is basically a calculation, and you plug in 4 numbers, the H, the ALT, and the AST, and the platelet count, which is very, very simple because we usually, when we do blood tests,
standard labs.
it's very standard labs and it's available. So you can actually plug in these numbers in the calculation. Anything less than 1.3, that means it's a very, very low probability of having fatty liver disease.
Cool.
Anything above 2.67 is significantly high, and those are the patients that will need to be referred to a liver specialist because they have advanced liver disease. And anybody in between the 1.3 to the 2.6, those are the patients that you and I see in our clinic, and we do the workup and follow them. So this is a very simple thing. There is a more sophisticated test called the ELF, ALF, and that ELF scoring is also an FDA-approved test, but it's on the expensive side, and not all of the insurance will cover it, so it can be a little bit cumbersome, and not all of the labs are doing it. And that ELF score also is a very good scoring system. Anything less than 7.7 means it's unlikely to have fatty liver disease. Anything above 9.8 means there is a serious disease, and anything in between, it's called intermediate, and those are the patients that we manage medically. There are two ways of imaging that. There is a new technology called elastography, which measure the stiffness of the liver, and it also will calculate the amount of fat in the liver.
Okay.
So there is a test called FibroScan, which is the one that we have at our weight loss clinic, that has been exceptionally helpful. It is very inexpensive. It costs about $45, and sometimes the co-payment for the patient is zero. So it's not really that expensive. And most of the insurance plan do not mind doing it because it's very inexpensive and it's a very good screening.
Okay.
So you can measure what's called the S score, S as in Sam. So S stands for steatosis, or the fat in the liver. So S0 means less than 11% of the liver is occupied by fat. And then there is S1, 2, and 3, mild, moderate, and severe. And then there is the F score, or the fibrosis score, which goes from 1 to 4, which is the one we talked about earlier. There is a more sophisticated way that you can get an MRI, something called MR elastography, which is a little bit more sophisticated than the FibroScan. Or you can get something called MRI PDFF, which also a very helpful way of telling the stiffness of the liver. So you have two choices of imaging study. You have two choices of blood test. And you put those two together, you can actually have a very good predictive value if the liver disease is mild, moderate, or severe.
So you're using the FibroScan to determine the severity of the fibrosis.
Correct. So
before you make the diagnosis, are you doing a standard ultrasound or a different type of test?
There are multiple guidelines from our endocrine society and also from the liver society, and they both agree that a good, simple, and cheap and inexpensive screening test is the FIB4.
Okay.
And again, you can get that scoring system by simply plugging the liver enzymes, the platelet, and the patient age. If it's less than 1.3, you don't really have to do much. If it's above 1.3 to 2.6, this is when you choose your favorite imaging study. At Primary Care, because we have the FibroScan, so we usually do the FibroScan, and we get a steatosis scoring and a fibrosis scoring. It's a little bit more information than your typical ultrasound, because the ultrasound will tell you if you have a fatty liver or not, but does not really stage the degree of the fatty liver, and does not really distinguish the steatosis and the fibrosis. So the FibroScan is definitely give you more information.
Okay.
So someone who has, like one of your patients who has diabetes well controlled, like maybe their A1C is 5.9,
Sure.
They're overweight, but all their liver function tests are good. Is it standard care for you to plug this stuff in and just say, or do you expect it to be standard care with primary care physicians to plug this in and do the FIB4?
Again, if the liver enzymes are fine, and so there is really no issue, but it takes 5 seconds to calculate the FIB4 score, and it doesn't cost anything because you open the patient chart, you have the information, their age, the platelet count, the liver enzymes, and there is actually a formula that we can incorporate in our electronic medical record, and it will give you the number immediately. So it's actually a very good screening test. If the FIB4 score is fine, but the patient have some other risk factors, and at some point in the past they have abnormal liver enzymes, I probably will watch them a little bit more closer, and maybe at some point I will get a FibroScan. But if the liver enzymes are fine, even though they could be diabetic but under control, they could be overweight but their weight is stable, I probably would not go that far further than that.
Right, because they have normal liver function studies. It's hard to think. I mean, it would be unusual that they would have fatty liver that's of any great severity, wouldn't it?
Again, it's hard to tell the severity of the liver disease from the liver enzymes because liver enzymes usually tend to spike and then they come down. So it depends on what time or what point you catch them. And that's why the screening with the FIB-4 is really, really very simple. And you can calculate the score and take it from there.
I would think, though, if you're calculating where they stand with the FIB-4, if they have completely normal liver chemistries, that it's probably going to turn out most of the time being normal, no?
Correct. I mean, unless the FIB-4 is going up, but if the FIB-4 is fine, you don't really have to do anything. And actually, all of the guidelines from both the Liver Society and the Endocrine Society, they say if your FIB-4 is normal, you can stop there, but you're still going to see the patient on a regular basis. So, and one of the standard blood tests that we do is the liver enzymes periodically, whether it's every 6 months or every year or every 3 months if you are doing an A1C every 3 months. So you will be able to tell. But the patients who are identified as risk factor are patients with obesity, patients with multiple abnormality of the metabolic syndrome, whether it's the blood sugar, the lipid, or the blood pressure.
I know there are some docs out there that will make the diagnosis with an ultrasound and then go to a fibroscan, but that almost seems like it's duplicative in some ways.
Correct. So if you are suspicious that the patient might have some fatty liver disease based on the blood test and the FIB-4, I probably will go straight to the fibroscan. However, the fibroscan is only looking at the liver, but the ultrasound, they are looking at multiple things. So if you are concerned that they might have a gallbladder disease, probably ultrasound might be more beneficial.
Okay.
So I have a couple of questions from that. If you're going back a little bit to what you said earlier, if you happen, like a lot of people that try to lose weight, they'll like I just lost a bunch of weight for my daughter's wedding last year, and then I've gained some of it back. So you have that like yo-yo, so what happens to these scores, and does it get harder to move the dial with the...
It actually gets worse because for every 10 pounds you lose, it's 8 pounds of fat, 2 pounds of muscle. Every time you gain 10 pounds, it is 10 pounds of fat and 0 muscle. I know life is not fair. But, when you lose the weight and you gain it back, you're actually gaining more fat and you're losing less muscle. And when you lose muscle, your metabolic rate slows down, so it makes it harder to lose the weight. And when you have more fat in the liver is worsening of liver disease, more fat in the blood, worsening of your cholesterol, more fat in the arteries, increase the risk for heart disease. So when you lose the weight and you gain it back, you actually end up in a worse shape than where you start.
Yeah, I've noticed that with my patients too.
So I guess this is why too, like it's so important with your clinic that they handle that piece with like lifestyle and do some teaching with that as
and
well.
We tell all of our patients on day one that the journey is 2 stages. Stage number 1 is to lose the weight. Stage number 2 is to maintain the weight.
That's the harder part.
Think of the weight like an elastic that you stretch it and it is nice and straight. But once you relax and you allow it to recoil, it goes back to its previous shape.
Yeah.
So the weight loss, believe it or not, is the easier part. The weight maintenance is the harder part.
The hard part, yeah, absolutely.
It's not really hard, but it is harder because you need to change your lifestyle forever.
Right.
So we usually put our patients on a strict diet for the first 3 to 4 months. I actually should not say the word diet. We call it a meal plan. For the first 3 to 4 months, and then we increase their calories slowly once they enter the maintenance phase, but they still have to be very selective of the quality and the quantity of the food. During the weight loss, you need to spend 150 minutes exercising every week. During the maintenance, you need to spend 250 minutes every week. And all of the skills that you learn during the weight loss, you need to maintain during the weight maintenance, which is increase your water intake, make sure you're sleeping 7 to 8 hours. You need to learn how to deal with stress. We call it mindful eating, especially over the holiday. And if they are on medication, that medication need to be either adjusted or maintained if they are not having any adverse effects. So it is a long-term process because it's a chronic disease. It doesn't go away.
Right.
Dr. Yacoub, why does sleep impact weight?
So people who do not sleep well, they tend to have increase of the stress hormone. And that usually does not really help when you're trying to lose the weight.
Okay.
Besides, it will take away a lot of their concentration and energy. And to be successful with the weight loss, you really need to be focused. You need to plan your food ahead of time. You need to keep track of your food intake, your water intake, your exercise minutes. So just imagine you're sleep deprived all the time. You might be able to do it for a week or two or a month or two, but long term, it's not. So one of the things that we do on the very first day at our weight loss clinic is we screen for sleep apnea. And we probably pick sleep apnea in about 15 to 20% of our patients. And once they are treated and their sleep pattern improves, they do very well.
It's amazing how much better people feel when they get their sleep apnea treated.
Yeah, I mean, just imagine you are sleep deprived and all of a sudden you sleep 6 to 7 hours of deep sleep. You wake up refreshed, you have the energy, the concentration just to start your day and be successful.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So we're going to get back to fatty liver, I promise, but I have one question for you just about lifestyle change and particularly exercise. So you mentioned about adding muscle mass to kind of improve, I guess, metabolism and whatnot, which I'm a big believer in. So when you're giving recommendations for exercise, how much of that is resistance training versus aerobic exercise?
So our ultimate goal is on any given week will be 150 minutes of cardio.
Okay.
And between 30 to 60 minutes of resistance training. Obviously, everybody's different depending on their conditioning. So some patients who have not exercised for a long time, we usually start with 10 to 15 minutes of walking 3 times a week.
So walking,
it's a great cardiovascular as long as you walk at the same pace.
Yeah.
And we usually ask them to find like a flat surface so it will not be very challenging, especially at the beginning. And our goal is every week we increase by 5 to 10 minutes.
Yep.
And eventually the goal will be 30 minutes times 5, whether it's exercise bike or a treadmill or just simply walking outdoors. As far as the resistance training, one of the things that we love is the stretch bands.
Yep.
They are very inexpensive. They cost $20 and they come in a bundle of low, medium, and high resistance. We start with the low resistance, 10 minutes, 3 times a week. And we usually ask them one time to do upper body, one time lower body, one time core. So it will be a full body workup with very, very little chance of hurting themselves. So we usually do not start with the free weight because if they don't do it correctly, they can hurt themselves.
Yeah, that's a little tough.
And with the stretch bands, you can again increase by 5 minutes every week with the goal of half an hour 3 times a week.
Okay. Yeah, that sounds about right from what I recommend too.
So resistance training tend to preserve muscle mass. If you do it on regular basis, half an hour 3 times a week, you actually increase your muscle mass while you're losing fat. And that's the ultimate thing, is preserve your muscle or increase it while you're lowering the fat. Your metabolic rate tend to increase, which basically will help you to maintain the weight. And when people tend to exercise on regular basis, they feel good about themselves. And that become the new norm. So they will wake up in the morning and they are looking forward to do their exercise before they go to work.
Very good.
I have a general question too before we run back into the fatty liver. Is as we're talking and just like listening to all the knowledge that you have with this specialty, at what point does a diabetic get referred, or should they get referred to an endocrinologist for their diabetes? And when does the PCP like hand over some of the care to the endocrinologist? What's that sweet spot?
Yeah, there's usually not a specific recommendation. I mean, every physician have their comfort level.
Yeah.
So some physician, they do not want to deal with the diabetes and they would like the patient to see an endocrinologist right from day one before they acquire bad habits.
I think you'd be overwhelmed if we sent you all our diabetics.
Yeah, well, obviously it's not practical.
No.
But most of the physicians, they usually will manage their patient on 1 or 2 medication. And as long as they are well controlled, obviously there will be no need for the referral. But once you start to be on like 3 medication and you are not controlled, it's probably time to add like more complexity to the treatment.
Yeah.
And this is when it comes to referral to endocrinologist.
Yeah.
Okay.
I mean, that's pretty much what I do. And anyone who's
Yeah.
really complicated, obviously, if they're going to be on an insulin pump, I don't, deal with that. That's a whole other level of complexity. But, if they're well controlled on a couple meds too, even 3 meds, I take care of them. But you start to get into, as mentioned, more than 3 meds, or they're on a pump, or their insulin regimen, if they're on insulin, is really complicated too. And they're having significant swings. This is how I think about it. They're hypoglycemic, then they're hyperglycemic. They're just really, I guess, fragile. And those are hard patients to
Very
really
true.
manage.
So among the 35 million people with diabetes in this country, 95% have type 2 diabetes. Only 10% of them are seeing endocrinologists, and the other 90% are managed by the primary care.
Yeah.
Type 1 diabetics, which is 5%,
Probably the other way around, I'm betting.
are the other way around. 50 to 60% of them are seen by endocrinologists because they tend to be much more complicated,
Yeah.
more fragile,
Right.
and a lot of them on insulin pump and sensors, which is very, very time-consuming,
very
labor intensive.
complicated.
And this is what we do. I mean, the primary care are dealing with their heart disease, their chronic kidney disease, their COPD, their arthritis. So, spending all of that time managing type 1 diabetes tend to be overwhelming. So we get a lot of referral for the type 1. But, at the end of the day, type 2 diabetics are 9 times more than type 1. So the vast majority of the patients we see are type 2.
Okay.
Well, let's get back to fatty liver. This was a nice diversion, though, because I think it's a lot in relation to fatty liver that we talked about, which is important, of course. But the name for it was NASH, and now it's MASH. And maybe you can explain what NASH is and what MASH is and why it changed and what all this is about.
Sure. So NASH stands for non-alcoholic fatty liver disease, which basically encompasses anything that is not alcohol related, but it's not really specific to the fatty liver. So the new acronym is MASH, which is metabolically associated steatohepatitis.
So it's more specific.
So it is more specific, and it actually captures what we are talking
It makes
about.
sense, yeah.
And it actually, I think it will be more helpful when physicians are starting to use the term MASH. They are actually thinking of the metabolic abnormality associated with the liver disease.
Yep.
And that's exactly the whole point about changing the
It
name.
makes perfect sense because there are other diagnoses that are encompassed in that, non-alcoholic steatohepatitis.
Correct.
It's
Like
really
you have-
it's a mouthful.
It's
but,
a mouthful. That's why they call it MASH-NASH.
Yeah, right.
So you have the autoimmune liver disease, you have the viral hepatitis.
Right.
All of those things have nothing really to do with the fatty liver disease.
Sure.
So the metabolically associated steatohepatitis is probably more focusing. And within the Hepatology Society, they are actually having specific recommendation for the MASH. So it's not really part of the whole liver disease. They are actually putting a lot of time and effort raising awareness, writing guideline. And there are tons of compounds that are being studied in that particular field.
Okay, great.
Is this a slow progression or a fast progression?
It is a slow progression, and that's why those patients, they will need to be followed by the primary care because they see the primary care more than any other specialist. And as long as liver enzymes are steady, that means they are fine. But once the liver enzymes start to rise and start to have more and more component of the metabolic syndrome, this is when you really need to focus more, and it become more time consuming, and that's the time when you probably need to get a liver specialist involved. They don't have to see the liver specialist that frequently, but at least once a year, just to make sure that there is a nice collaboration between the PCP and the liver specialist at the end of the day to the best interest of the patient.
So we already talked about this, but I just want to summarize for our viewers. So the risk factors for MASH, basically we're dealing with obesity, diabetes, people who drink a lot of alcohol, I'm guessing, is potentially a risk factor.
Well, for liver disease, but not necessarily,
Not necessarily for
MASH.
fatty liver.
But there might be some overlap, so it's always important to ask the patient.
There are
about the alcohol
genetic
intake.
predispositions, which we see probably in the Fall River area. here being.
Correct, with the obesity and the diabetes and the other components of.
Is there anything that we're leaving out here as risk factors for this condition?
No, you covered it. So the family history, the obesity, the diabetes, the metabolic syndrome, which is the high triglyceride, low HDL, and abnormal liver enzymes, which all actually of the primary care doctor are screening on regular basis, at least once a year.
Sure. So there's a new med out. I mean, in the past, it was always when someone had this, you and we still tell them the same thing, of course, lose some weight, have a low-fat diet, exercise, which is incredibly hard for some people to do, and that's understandable. We know that. But tell us about this medication that's available now, because this is, I think, really, it's going to be kind of cutting-edge news for a lot of our viewers.
True. So, again, just to add to what you did. So once the patients start to have some progression, or you feel that the liver enzymes are getting higher or the fibrosis score is getting higher, it's always good to refer to a liver specialist, because they will do a whole battery of testing to make sure that we are not missing on anything.
Sure.
Like a viral infection that could be contributing, or if they have any autoimmune disease. And if there's no other cause and we are dealing with fatty liver, basically, sometimes the liver specialist, they refer the patient to us for somebody like me to kind of intensify the weight loss, and sometimes they can start medication. So there's a new medicine called resmetirom, and resmetirom was approved by the FDA sometime earlier this year, February or March. It's an oral therapy. It's a pill you take once a day. And the FDA require for any medicine to be safe and be approved, you need to do two things. Number one, you need to improve the fat scoring, which is the steatosis scoring, without making the fibrosis or the scarring worse. Okay. Or you need to improve the fibrosis scoring without making the fat scoring worse, because sometimes you can improve one and not the other. So it is a requirement for any medicine in that field that it will have favorable effect on one without adverse effect on the other. So that medicine showed to decrease the fibrosis score by 1 point, and it was studied in patients with F2 and F3. So this is mild to moderate fibrosis of the liver, and they showed improvement of the fibrosis by 1 point without worsening the steatosis or the fat content on the liver. And it also showed to have some benefit on the cholesterol. So it lowered the cholesterol, the bad cholesterol LDL, by about 15%, lowered the triglyceride by about 12 to 15%, and lowered something called ApoB, which is one of the markers for heart disease, by also 15%. The side effects is mainly nausea, and it tend to be well tolerated, and it comes in 80 and 100 milligram. So you can adjust the dose up and down depending on the patient tolerability. There is a little bit of drug-to-drug interaction, especially when it comes to the cholesterol medicine. So we just need to be aware of the background medication, and most of the liver specialists are very, very knowledgeable about that.
Can you use the cholesterol meds with these meds?
You can use it concomitantly at the same time. However, some of the medication, like fenofibrate, for example, you need to lower the dose because there is a potential increase in the concentration of that medicine, so to avoid any potential side effects.
Okay.
So when do you start this? I know you said the study was for F2, F3.
Correct. So for those patients who meet the criteria, they would benefit from something like that. Okay. The other thing that we all have been known all along before that medicine was approved, that weight loss tend to improve fibrosis score. 7% weight loss will improve your steatosis score, which is the fat in the liver, and 10% weight loss will improve your fibrosis score. So I'm not a liver specialist, so I do not really prescribe that medicine very frequently. I usually would defer to the liver specialist, but we know for a fact that some of the diabetic medication that are available, one of the secondary benefit is weight loss. And some of those medication in clinical trial showed improvement in the early stage of fatty liver. So they decrease the fat in the liver, but they do not improve the fibrosis, but they do not make it any worse. Okay. They are not indicated for treatment of fatty liver. But if you have somebody who happened to be diabetic and overweight with early stage of fatty liver disease, you can treat the diabetes while you're helping them to lose the weight. and you can actually improve their liver disease. So again, those diabetic medication are not approved for liver disease. They are approved for treatment of diabetes. And one of the secondary benefit is weight loss. And one of the tertiary benefit is improvement of the fat content in the liver.
So if someone is struggling to lose weight, they can stay on this long term too, right? On this medication long term. Like if
Which medicine? The one for the fatty liver, the resmetirom?
Yeah, the resmetirom.
So resmetirom does not really have any effect on the weight. So it does not really work by helping the patient to lose the weight, but it does have a stabilizing effect on the progression of the liver disease. So one of three things will happen when you take that medicine. Regression or improvement, and obviously that's a very good reason to continue the medicine. Number two, no progression, which is also not a bad thing because sometimes liver disease tend to be progressive. So if the liver condition is stable, that's another good reason to keep the patient on the medicine. But if they are not responding and they are progressing, obviously there will be no point of continuing the medicine. And this is when you stop and you try a different strategy. Okay.
I hope that one of the messages from this podcast is no matter what you have, you shouldn't, I mean, you can be concerned about your diagnosis, but you shouldn't be too scared because there's so many things available out there. Like, I know some people may be hesitant to go see their primary care physician every year because they know they're out of control. They know their numbers aren't good. They know they haven't been good. Their weight's up. It's like all these things that make you
They say, I'll go to my doctor when I improve these things, and then 5 years have gone by and nothing has changed. Or it's gotten worse. Yeah. We see that all the time.
We see it all the time, but I always tell my patients, it's like a car. You need to do your tune-up on a regular basis. What will happen if you do not change the oil and do not do all of the regular maintenance? Right. Something will go wrong. So even if there's something wrong, you can actually catch it early, deal with it before it becomes a problem. So unfortunately, in medicine, Chris and I were dealing with a lot of chronic disease. And most of the chronic disease have no symptoms. Whether it's diabetes or high blood pressure or high cholesterol or fatty liver disease, you really have no symptoms. You just go on with your day and you have no problem. But at
until you have a problem,
it will catch up with you. And once you have a problem, it might be, hopefully not, but it might be too little, too late.
Yeah.
Right.
So it's always good to do the tune-up, the preventive medicine, the screening for any problem. And if we find something, we fix it. And most of those manifestation of the liver disease are completely reversible if you catch it early, you take it seriously, and you make some adjustment of your lifestyle, and obviously follow up with your doctor.
What's the percentage of patients that develop end-stage liver disease from fatty liver?
I mean, there's not really very clear data, but it is definitely not as high as you think. So even though we have 70 to 90 million people with manifestation of liver disease, but it's less than 10%.
Yeah.
But those people with the 10% are the ones who are going to have some serious problem. Right. And unfortunately, it is increasing everywhere. So they did a study in different parts of the world, and they found that 1/3 of the population on Earth have some degree of fatty liver disease, mild, moderate, and severe. In the United States, it's about 32%. But the sad thing is they started to screen kids under the age of 18. And now it is 6.2% of kids under the age of 18 have already manifestation of liver disease because of childhood obesity.
Right.
So it is on the rise. And unfortunately, if we don't do anything about it, it will continue to progress and it will be a major problem.
So, I mean, there may be a small percentage that go to the stage of end-stage liver disease, but when you're dealing with a condition that is so prevalent, that small percentage it accounts for a lot of patients.
Very true.
And regardless of how small that percentage is, even if it's not common that you would end up in that scenario, if you end up in that situation, boy, that is really a bad situation.
That's true. That's why it's always good to catch that at F2, not at F3 and F4.
Right.
Is this medication approved, FDA approved for children?
No, for adults only.
Okay. And I have another question. I don't know if you'll know the answer to this, but does this affect more men or more women?
It's basically related to obesity, so it unfortunately affecting both. Okay. Women tend to seek help earlier than men. So women tend to be sensitive to weight gain, and they tend to go to the doctor and ask for help. Men usually do not ask for help early on. They wait until, unfortunately, I'm not generalizing, but
We
generally
suffer
speaking,
in silence.
yeah.
Not me. I'm the exact opposite. I can't speak for all women, but
But that is true. It's true. You know, a lot of men just, they don't really follow up on
Our
this stuff.
weight loss clinic, 2/3 of our patients are women, 1/3 are men.
there's a lot to dig up on that.
Right,
but
right,
Out of
right.
that's probably
That would be
the
another
social
podcast.
media
It's a lot
pressures,
of
too.
societal, social media, body image. There's a lot of reasons for
Exactly.
that, right? That could be a whole other discussion.
Yeah, that would be a very interesting podcast, wouldn't it? Oh my
Just
gosh.
talking about weight issues between men and women and how their perception of that differs.
Yeah,
Yeah.
exactly.
Very interesting, yeah.
So is there a certain age that, like, what's the most, what age is this most prevalent at?
So it's extremely prevalent among adults. So 32% of the U.S. population, they have some degree of fatty liver disease. But the concerning thing is when they started to screen kids under the age of 18, 6.2% of kids under the age of 18. So it is on the rise, and it started to affect kids at a younger age because now childhood obesity in this country is going to be a major health problem. So I think this is something that can be done by both primary care physician and by pediatrician. And I think if you screen and you find abnormal liver enzymes, you just basically you do the same standard of care, lifestyle modification, and make sure you follow the liver enzymes. And if it is rising, you can always refer to a pediatric hepatologist. Those are liver specialists specialized dealing with kids.
Yeah. The whole childhood obesity thing is really interesting. I mean, I'm not a pediatrician, you're not, but I mean, what's your thought? Why do you think there's so much childhood obesity? I mean, I have my thoughts, but what are your thoughts?
It's the society. There is plenty of food.
Right.
And there is very little physical activity. So think about it. Back in the days when you and I were young in like elementary school and middle school, we used to probably spend like 10 hours, if not more, like every single week playing some kind of sport.
Absolutely.
Now the favorite sport for kids is video games. Where you're really not moving.
Yeah.
And back in the days, our school cafeteria had very limited options.
Right.
And now you have unlimited option. I actually went to visit
The land of plenty.
my son like last year when he was senior in high school for some kind of a function. And I passed by the cafeteria, and the amount of food that they have
It's incredible.
is incredible. Mac and cheese, pizza, potato chips, soda, juices. And you can see like at the very, very, very end of the corner, there is like fruits.
Right.
Like an apple.
Coming in.
You know, when I went to college, it'd be like 2 or 3 horrible choices. Now they have, now they have hundreds of choices to pick from. It's crazy. I see my daughter's in college.
Yeah, I think our lifestyle. And for kids, they are spending less time playing sport and more time sedentary, playing video games or watching some kind of a computer game.
It's so true.
The food is becoming more affordable, very, very cheap. And I have to say, it is very tasty, which really makes it an easy choice for kids to have unhealthy food rather than now going out of their way and having salad and protein.
Well, crummy food is cheaper in many instances.
And it's very accessible.
And it's accessible, and it's sometimes flavorful. So,
I read an interesting article, too, the other day about American food versus like European foods.
Sure.
And how even our bread is very sweet and has like a higher sugar content.
It's so different when I'm in Europe. I mean, it is just so different. The food quality just
That's why they call
very
it the
different.
standard American diet, SAD, SAD.
Yeah, it's sad. Yeah. But, like when I was a kid, and you may have had a similar experience, I don't know if you did, but I'd come home from school and we didn't have by the way, hours and hours of homework to do. But when our homework was done, my mom would say, go outside and come back when the street lights come on, right?
Yeah.
And then, if you were hungry, your mom would give you an apple, or she'd say, go pick some berries out in the woods or something. I'm thirsty. Go drink some hose water.
I get the hose water. I never foraged for berries.
I foraged for many berries in my life as a kid. Oh yeah.
Oh my gosh. So
But we didn't have closets filled with snacks either. There were like closets filled with chips and cookies and things like that.
We didn't have any of that stuff.
You didn't have that. It was a very different world, right?
We had kind of like one box of cookies that might have been on the cabinet. Everything else was kind of made.
It was exactly. So the world is very different now.
Yeah. Can I ask you a question too? There are a lot of people that take a lot of supplements. Have you known any supplement to like help with this stuff? Like milk thistle is a popular one.
Yeah, patients come in all the time. I'm taking a liver cleanser.
Yeah.
I would love to hear your, because I have my thoughts and what I tell them. But what are your thoughts on this?
So these are the things that kind of make me pause.
You don't sell them in your clinic?
So best supplements is to have variety of fresh fruits and vegetables of different color. So if you are taking supplements mainly for mineral and vitamin, the best source of mineral and vitamin is fresh fruits and vegetables. And we usually tell our patients when you prepare your plate, whether it's lunch or dinner, make sure you have at least 3 different colors. So that's basically the different fruits and vegetables and berries. So the more color you have on your plate, the better, because you will have more variety.
I'm thinking of Kentucky
minerals
Fried Chicken
and
with
vitamins.
mashed potatoes. It's all brown, tan, white.
tan, and the gravy's dark brown.
Not the kind of meal like you're talking about.
Oh, we're talking about red and green and
We're
yellow
talking about different shades of
purple.
Variations of
different
brown.
shades of brown.
Okay, jeez. So you thought you were going to get away with that, but you didn't.
Not my favorite. I'm okay with
I haven't
that.
been a Kentucky Fried Chicken in I don't know how many years.
Yeah,
God.
same.
Yeah, I'm sure it probably hasn't changed in 20 years either.
So a lot of fruits and fresh vegetables, a lot of screening.
Foraging for berries in the woods, too.
So, oh my gosh, that's what we're going to label this podcast, Foraging for Berries, helping your fatty liver. So then, as a summary to wrap up the discussion on fatty livers, what would be your main messages to the audience?
Go and see your primary care doctor on a regular basis, and if there's any abnormality in the liver enzymes, or if you're overweight or obese, or if you have diabetes or high blood pressure or abnormal cholesterol, they should probably do that FIB4 screening. And if it is abnormal, you might probably pursue with some kind of imaging study. FibroScan is very, very inexpensive. It's painless. There's no injection. You do not go through a tube. It basically takes 5 to 10 minutes to finish from beginning to an end. And follow up with your doctor. If your liver enzymes are stable, slightly abnormal, the best way is lifestyle changes.
Right.
Change your eating habits, exercise. If you are obese, not just overweight, you might seek some professional help at a weight loss clinic. And studies showed that 7 to 10% weight loss can make a huge improvement in the health of the liver.
Great.
Nice.
That's great advice.
Yeah. I think you had said that when you had done your podcast with us on
About the
weight loss
10%,
and how significant that is. And I think that's been, we referenced that a lot during our other podcasts. Yeah.
Me too, yeah.
I mean, you don't really have to lose 15, 20% of your weight, just as little as 7 to 10%. Lower your risk of diabetes, improve your fatty liver disease, lower your blood pressure, improve your cholesterol. Less pressure on your joints. If you have reflux disease, it goes away.
Right.
If you have sleep apnea, it improves. And sometimes
It's remarkable how many things it helps.
It's a
really.
life changer.
It
And we're talking about 10%. We're not talking about a major,
No.
50 to 100 pounds. We're just talking about 10%.
I mean, a lot of times patients come in and I want to get my ideal weight. What's my ideal weight? I said, 10%. That's what you need to lose.
We'll start with the 10%.
Start with that, and
take
we'll
it
talk
from there.
about that.
Exactly.
Because I think if you look at the big, you look at this goal that's unrealistic, you just get overwhelmed and you're going to give up.
And it become very disappointing. So we usually set the record straight on the very first visit. So somebody say, I would like to get to my high school weight. Said, what was your high school weight? Said, like 100 pounds. I said, okay, to lose 100 pounds, you need to lose your first 15 to 20 pounds.
Yeah.
So let's do a first goal of 15 to 20 pounds. And when we get there, let's set another goal and another goal and so forth. And, patients who have a number in mind that they do not reach, they drop out of the program. And then they show up a year later and their weight is even higher than when they started.
Right.
So baby steps. And actually studies showed as little as 3 to 5% weight loss will improve your blood sugar significantly. but you start to get the mechanical benefit of the weight loss at the 10% mark.
Yeah.
So for the sleep apnea reflux disease, most of the metabolic benefit happen at the 5 to 10% weight loss, which is the fatty liver disease, diabetes, blood pressure, and cholesterol.
Okay.
This
Thank you.
great summary.
Awesome. Thank you
was
very
a great
much for
podcast.
having
I
me.
can't believe a whole hour went by. So
I know.
I'm always amazed with these podcasts, how quickly they go. And it's
especially
something
Dr.
rich.
Yacoub, because
Yeah,
it's like
especially
an
when
hour
it's
is 10 minutes.
interesting topic, interesting speakers. So
Yeah.
it always goes by quickly. So I want to thank everyone for listening to our show. And if you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music, Primacare, your trusted medical providers in southeastern New England, and the Bioskills of Northeast for producing our show, and available to produce your show by calling 774-301-8811, and they do a great job. Baycoast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And of course, thank you, Dr. Yacoub, for being here with us, spending this hour with us, and discussing such an important topic. It's really interesting, and we appreciate you being here and giving us your time.
Thank you very much for having me. I appreciate it.
Thank you.